Welcome back to The Explainer. So, if you're a radiation oncology resident out there who's currently just drowning in a sea of trial data and contouring guidelines, trust me, you are in the exact right place. Today, we're taking some of the most absolutely critical landmark CNS trials and modern guidelines, and we're synthesizing them into high-yield pearls. We're going to cut right through the fluff. We're focusing purely on what you actually need to know to excel in the clinic, and, let's be real, to absolutely crush your board exams. So let's take a structured look at the data that shapes how we actually draw our targets and choose our therapies.
Okay, let's dive into this. Here's our roadmap for the explainer today. We're covering elderly GBM and key trials, target volumes and margins, Rano criteria and progression, anaplastic gliomas, and finally, pediatric low-grade gliomas and SRS.
All right, moving right into Section 1, Elderly GBM and Key Trials, specifically looking at systemic escalation. Now, right before we look at the actual data, we need to quickly define a concept you're definitely going to see in the literature, and that's the Sucra ranking. Basically, it's just a statistical method used in network meta-analyses to rank the probability of each treatment being the absolute optimal choice. It essentially tells us, out of all the options tested across a bunch of different trials, which one mathematically comes out on top. Keep that in mind as we look at the CALRA 2020 meta-analysis.
So here is your board-style bottom line for elderly GBM. The CALRA 2020 network meta-analysis looked at 7 randomized trials to rank overall survival outcomes. The Sucra rank 1, meaning the optimal choice, is 40 gray and 15 fractions of radiation combined with concurrent and adjuvant temozolomide. But here's the critical clinical pearl. If you're looking for the absolute best radiation-alone approach, maybe because your patient just can't tolerate chemo, rank 2 is 25 gray and 5 fractions. It actually outperformed 40 gray RT alone and TMZ monotherapy.
Now, what about escalating systemic therapy for newly diagnosed GBM? Well, we have to contrast 2 very different strategies here. First up, the CTG trial. This looked at adding CCNU or lomustine to TMZ and RT in MGMT methylated patients. And this actually yielded a really significant overall survival benefit, pushing median OS from 34.1 to 48.1 months. Now the major caveat? Pretty high toxicity. Compare that with RTOG 0825 and Avoglio. Those trials added bevacizumab to standard chemoradiation. And the result there? A significant progression-free survival benefit, but absolutely zero overall survival benefit. Look, distinguishing between an OS benefit and a PFS benefit on these trials is an absolute must for the boards.
Okay, let's pivot to Section 2, Target Volumes and Margins. This is all about shrinking the target. Let's move to this next concept and see how this builds historically, because it's fascinating. Back in 1989, Halperin established the rationale for what we'd now consider massive expansions. We're talking treating the edema plus a whopping 3-centimeter margin. By 2007, MD Anderson was championing the T1 contrast-enhancing tumor plus a 2-centimeter margin. But then, trials like RTOG 0525 proved something really important. The vast majority of failures were central. They were happening right inside the high-dose field, regardless of how wide we drew our margins. This realization is what eventually paved the way for the 2016 ESTR-ASCR-PPO guidelines, moving us to a much tighter, single-isotropic CTV. You can really conceptualize this steep drop in target expansion size over time, going from that towering 3-centimeter historical margin all the way down to modern sub-centimeter margins. The absolutely key takeaway from studies like Maniti 2010 is that adopting these smaller margins did not, I repeat, did not increase marginal or out-of-field failures. It turns out the tumor biology, not our crude anatomic margin, dictates the failure pattern. Now, these anatomic barrier rules from the 2023 ESTRO-EANO guidelines, these are highly testable. You can reduce your CTV expansion to 0 millimeters at the skull, falx, tentorium, optic pathway, and brainstem. You can give a 5 millimeter margin at the ventricles. But you've got to memorize this. You are absolutely not allowed to reduce margins at the corpus callosum or the cerebral and cerebellar peduncles. Why? Because tumor tracks so readily along those specific white matter pathways.
Moving right along to Section 3, Rano criteria and how we define progression.
So the Rano criteria were created to address a massive daily problem in the clinic, pseudoprogression. That's where the tumor actually looks worse on an MRI, but it's just from the radiation effect, not actual tumor growth. Notice the absolutely critical split at the 12-week mark post-chemoradiation.
If you're 12 weeks or less out from treatment, a clinical decline alone literally means nothing without histologic proof or a brand new area of enhancement totally outside the radiation field. But the second you cross that 12-week threshold, a 25% increase in tumor size or unquestionable clinical deterioration is completely sufficient to call it true progressive disease.
All right, Section 4, Anaplastic Gliomas. Let's look at the landmark trials. Now, what's really interesting about this next piece of data is how cleanly it divides our standard of care in this sort of anaplastic showdown. RTOG 9402 is your go-to trial for 1p/19q co-deleted tumors, and that established PCV chemotherapy as the gold standard. Contrast that with CATNON, which is the trial for 1p/19q non-co-deleted tumors, which are predominantly your IDH mutant astrocytomas. CATNON proved that while there's no benefit to concurrent temozolomide, adding 12 cycles of adjuvant TMZ provides a massive, real, overall survival benefit.
14.7 years. I want that specific number to firmly stick in your head. 14.7 years is the dramatic median overall survival for 1p/19q co-deleted patients receiving PCV plus radiation in the RTOG 94-02 trial. Now compare that to just 7.3 years for the folks who received radiation alone. That is literally a doubling of survival simply by adding the right chemotherapy to the right molecular profile. It's huge.
Rounding out the anaplastic gliomas, we've got the NOA-04 trial. Now, this was an equivalent study asking a simple question. Does it matter whether you give radiation first or chemotherapy first? And the answer? Nope, it doesn't. There was zero difference in overall or progression-free survival based on that initial sequencing. Also, just rapid fire, you absolutely need to know your favorable molecular progrestic factors, an oligodendroglio component, an IDH1 mutation, and MGMT promoter hypermethylation. All three of those indicate a much better prognosis for your patient.
Section 5, Pediatric Low-Grade Gliomas and Post-Op SRS. We're looking at contouring rules and systemic therapies.
Listen closely here. When you're contouring a cavity for post-operative SRS, you cannot just circle the hole. It doesn't work like that. You absolutely must fuse the preoperative MRI to understand the original tumor extent. You need to contour the entire surgical tract all the way to the brain surface to prevent tumor cell seeding. If the pre-op tumor touched the dura, you've got to extend your CTV 5 to 10 millimeters along the dura. And if it was touching a venous sinus, you extend up to 5 millimeters into that adjacent sinus. Please, memorize these specific millimeter expansions for your exams. They love to test this.
Let's finish up with pediatric low-grade gliomas. Pilocytic astrocytomas are commonly driven by a brave fusion, which we target with tovorafenib. Meanwhile, pilocytic xanthoastrocytomas are often driven by a brave V600E mutation. So, the absolute crucial point here is this. Do not, under any circumstances, use dabrafenib and trametinib in a child with a brave fusion. It causes this paradoxical activation of the MAPK pathway and actually makes the tumor grow faster. It is a very, very common trick question. Lastly, just remember that for these kids, radiation is strictly reserved for older children and only after we've completely exhausted our less toxic targeted and systemic options. Wow. Okay, we've covered a tremendous amount of ground today. Everything from the massive margins of the 1980s right up to the hyper-targeted molecular inhibitors of today. And I really want to leave you with this final, somewhat provocative thought to ponder for your future practice. As genetic markers like IDH, 1p/19q, and BRAF dictate survival far more heavily than whether we add an extra half centimeter to our CTV, are we rapidly approaching an era where a tumor's molecular profile entirely overwrites our traditional anatomic radiation volumes? Think about it. Anyway, thanks so much for joining me on this explainer. Keep studying hard, trust the process, and I'll see you next time.